Okay. We have many of you who are watching online, so thank you very much for joining us where you are. So before we get started, I'm going to go over just a few things to help everyone online get accustomed as well, so they know how to ask their very important questions, and I'll go over a few things here. So to start out, before I get started, I'd like to recognize the generous support of our corporate sponsors who help make these very important patient education programs available. And thank you to Alexion, Apellis, BioCrest, Bristol Myers Squibb, Genentech, Novartis, Regeneron, Servier, and Taiyo Oncology. And also I'd like to thank the very generous support of our patients, families, and caregivers who help support this program today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or a comment, just type in the question in the Q&A text box, submit enter, and we will be rotating between questions in the audience and online. We will do our best to get to all questions today. I do ask two things when you're submitting questions and asking questions in the audience. Online, submit your question all at the same time. That way we don't have to try to piece together information. We want to make sure that we're asking all of your question at the same time. We do ask for everyone to please not share private health information in your question. Our expert speakers cannot answer any specific questions related to your personal health care. As Dr. Tantarahi mentioned, our speaker today is Suneet Agarwal, and he is the co-program leader for the Stem Cell Transplant Center at Dana-Farber Boston Children's Cancer and Bone Blood Disorders Center. He's also an assistant professor of pediatrics at Harvard Medical School. It's my pleasure today to welcome Dr. Agarwal. Thank you for joining us. I'm going to ask him about this.
Thank you so much, Lee, and thank you, Dr. Pulsiver and Dr. Tantarahi, for inviting me to this session. Should I use this microphone, or do you think
I'm going to double check.
Okay, I'll keep using this until we find out if there's other audio support here. Well, it's a real pleasure to be here in this beautiful setting and to engage with the AAMDS International Foundation, which is the first time for me. I'm a pediatric hematologist and bone marrow transplant physician, and so I know that that's not often the part of the agenda of the AAMDS International Foundation, but thank you for including pediatrics in the agenda. I run a lab that tries to study genetic blood disorders that come up with new therapies. And I think that my goal today is to explain to you our approach in pediatrics for bone marrow failure disorders and MDS, and hopefully the lessons that can be applied across the age spectrum as well. So today we're going to talk about stem cell biology and genetics and try to get a little bit deep into it. But what I'd like to do is provide a conceptual framework for how we think about what's happening in bone marrow failure and then leading to MDS. So there'll be a lot of science there too, but I think it's easier if we break it down into like a conceptual framework that everyone can understand. I'm okay with this. Okay. That's fine. So if you think about the hematopoietic system, so the blood system, blood formation, you can think about it as a garden. It's very robust and very dynamic. There's many, many cells that need to be made every single day in your body, billions of cells to actually provide the capacity to carry oxygen, to fight infection, and to stop bleeding. And they all kind of have their origin in the bone marrow with a stem cell. And the stem cell you can think of as a seed in that garden, but it has a special property that can give rise to any of those flowers, let's say, or any of those plants in the garden. And it's dependent both on its own integrity, but also that of the soil, the niche that it's in. And together, it is able to, in a lifelong way, renew itself, and then also on demand and as needed, provide all of what's needed for the garden. So this is what we like to see in the bone marrow. A bunch of different looking cells that are basically in various stages of maturation to give rise to all of those cell types in your body. And what happens in bone marrow failure? So when we see a patient with bone marrow failure, that means that something has gone wrong, either with the seed, the stem cell, its niche, the soil, or its process of being able to turn into those cell types that you would need. And that results in a deficiency in the peripheral blood of one or more cell types. Then the question becomes why? And we have a way of thinking about how to put this in categories that guides our diagnostics. So the first is, unfortunately, we don't know. big question mark. And it turns out that in this category of acquired or idiopathic aplastic anemia, there's probably a common phenomenon of an immune attack on the hematopoietic stem cell itself as well. So basically that's being depleted by some attack on its own. The other category is secondary. Some insult has happened, radiation exposure, chemotherapy exposure, known or unknown, some infections that will basically deplete this cell or its capacity to differentiate into the cell types you need. And then finally, what we're focused on in pediatrics, because it ends up being a larger proportion than in adults of what happens, is that the patient actually inherited a disorder. And that was always a problem with the blood stem cell and other cells in their body, because it's all the way throughout the entire body. And that turns out to be one of several syndromes that were named a long, long time ago that don't reflect bone marrow failure, but reflect people's names or essentially what it looked like the patient had. Fanconi anemia, dyskeratosis congenita, Schwachman-Diamond syndrome, and we'll talk a lot about those. So we try to bin these, and I'm going to be talking, of course, more. You'll be hearing in the session a lot about acquired aplastic anemia. I'll be talking more about inherited marrow failure syndromes and how we approach them. So the framework for this talk is, I'll talk about the pediatric approach to marrow failure in general, the importance of diagnostics, and how we use genetics to actually help find the disorder. And I'll talk about MDS predisposition syndromes, because these are also things that are inherited that give rise to MDS. I'll talk about the genetic evolution of blood stem cells, that genetic changes happen both that you inherit at birth, and also that happen in this very dynamic stem cell over the course of age to result in MDS, and how there's an interplay between marrow failure syndromes and MDS. And then finally, if we have time, I'll talk a little bit, very briefly, about research to try to address what are our challenges right now and how do we improve therapy now that you can actually diagnose and now that you can actually categorize what's happening in the patient. How do you now come up with therapies that are tailored to improve the outcome for the patient? So starting off with bone marrow failure, there's a set of criteria that we use to diagnose a person who has a problem that means that their blood system is failing. And it has to have two components. One is that there's actually a problem in the blood cells, and so severe defects in these blood cells would be considered an absolute neutrophil count, fighting inability to fight infections that's very low, a platelet count that's very low. Instead of being around 150,000 or higher, it's down to 30 and people start to have symptoms, or anemia, so red blood cell deficiencies, impaired oxygen carrying capacity, fatigue, and low reticulocyte count. These are the baby red cells. And so when they are low and you have anemia, you're having a problem with producing the cells themselves. And then when you look in the bone marrow, you have an abnormally low number of cells. So the factory is not producing the number of cells. So you have a production problem there too. But the cells otherwise, if we're talking just about bone marrow failure, generally don't look that abnormal. They look pretty normal. They may be trying to move along and become the cells that you want them to be, the flowers that you want to be in the garden. They don't look misshapen, they don't look cancerous, but there's just not enough of them, or they're being blocked in some sort of way. So that would define marrow failure rather than some other entity. And what other clues can we look then when we just see that of whether or not this is an acquired problem or if it's an inherited problem? So there's a couple things that are not perfect at all that we get to see in terms of giving us a hint. And one of them is one of them is the blood count trends. Did this happen all of a sudden? Or do we have any history in the patient that shows us that this has been going on for months, years, and slowly getting worse? There's another parameter that we can use, is the size of the red cells. Strangely enough, it has no impact on the function of the red cells, but are the red cells big? And if they're big, then that actually sometimes indicates some level of stress in the marrow that has actually resulted in large cells. And finally, can we see other factors like hemoglobin changes? We have one parameter called hemoglobin F. But that's pretty much what we get from the marrow in the periphery, and we need to do more to figure it out. So in terms of the clinical evaluation, there's a lot of questions that we can ask to also get hints. Again, not definitive diagnoses, but point us in the right direction. Things that would be suggestive of an acquired problem are things that would have insulted or stimulated the immune system, or indicative of an underlying immune disorder that would result in part in destroying the blood system. So that would be, you had a recent infection, and this is a side effect of that infection, that your blood cells got affected by an immune process trying to fix the infection. That you have a history of immune defects or autoimmune problems, and now you're attacking your own blood cells too. Things that would be suggestive of an inherited problem are several, and we go through these exhaustively in our evaluation of patients, especially children. Are there anything else, are there other things that went wrong with development? Is there something wrong with the birth history, the size of the baby at birth, how they're meeting milestones, what height they've attained at a certain age? Is there a family history, all the way up into older folks in the family, of blood diseases, cancers, something that might have been passed along, other organ disease, early death? And some of it doesn't seem intuitively related at all, and we'll go through that. But it actually is very, very pertinent. So we ask very comprehensive family histories and get involved our genetic counselors to take those histories for us. And then a very comprehensive physical examination, things that probably didn't seem like they really mattered, but actually might be indicative of there being a problem. Birthmarks that are abnormal, changes in skin pigmentation, changes in the hair or nails, subtle abnormalities in bone structure of the hands, of the thumbs, of the arms, for instance. And we also have to ask about any other part of the body. We ask, and maybe there's not a problem in it yet, but there's actually a problem going on underneath it. But we ask to basically say, yeah, those two things that seemed unrelated might actually be connected in some way and may be part of a syndrome. And so that's how we basically try to categorize. But beyond that, we actually now need to fit this into a diagnosis, if we can, of a marrow failure disorder. And I'll take you through the steps of what we do there and the relative power of these things. And this is what's evolved over the past 100 years or so, in terms of being able to name syndromes, find out what's going wrong with those syndromes, and seeing what they actually cause, and then the genetics of them. So the first one is, does the patient fit a clinical diagnosis? So fit a textbook description by the time we've gone through all those things. Do they say something to us that they actually really didn't seem connected, where we're like, you have this syndrome because you actually have these manifestations that wouldn't have seemed connected? That's a pretty typical genetics approach to finding an underlying disorder. So the first example I'll give is of Fanconi anemia. So this is the most well-known, the most prevalent of the inherited marrow failure syndromes. And it was described 100 years ago as patients who basically had a problem with their blood system, but also had other issues. In their skin, their pigmentation was abnormal. They could have skeletal abnormalities and short stature. And so the way these diagnoses come about is someone sees 2 or 3 of these patients and they say, there's something in common with them. This must be a syndrome. I can describe it this way, and we'll put the name to it. And that's really what happens. And then that lingers for decades, as you see in this case. You don't know what the underlying etiology is, especially in the early 1900s, but you say, this is connected. And then you start to see subtle aspects of it, maybe in family members, that aren't the full-blown effect, but you start to see the marrow failure and maybe one abnormality or none. And so quickly it becomes appreciable that this is something that's running in families, and some people have a syndrome, and some people have some manifestations of it alone. So occasionally milder features were noted in siblings, even early on. And by the 1980s, people who were caring for these patients, without again knowing what the process was, could say, actually the clinical features are often unreliable. We can't actually categorize people. We know that the people who have it, but we then end up in a category of, so we think some other people do have it. We need better tools to diagnose. So this is actually quite a remarkable example of a process of clinical diagnosis that was very useful, but then actually didn't lead to definitive diagnosis, and that evolved in the past 30 or 40 years. This is another example. This is a relatively common marrow failure disorder or spectrum called dyskeratosis congenita, and it was actually described in the early 1900s by dermatologists, and they were basically commenting on what looked like the outward manifestations of a systemic degenerative disorder, and those included what they call the classic diagnostic triad of pigmentation changes that you might be able to appreciate here on the skin, patchy areas of hyper or hypopigmentation, oral white lesions, and fragile or absent nails. And so these patients would have high rates of marrow failure too, high rates of lung and liver disease, and by the time you aggregated these patients and studied them, many other parts of their body could be involved too. But one of the most penetrating features, and that's why it was called a bone marrow failure disorder, is that by the age of 30, more than 90% of the patients actually had a problem with their marrow. But also by the time people were studying these in the 1990s, it was clear again, there's a huge amount of variability, and people were missing the diagnosis in some patients because you couldn't actually always see all of these classic manifestations we did. So what helps you get beyond this? So you have to understand the biology, and what's really been revolutionary in these disorders is functional testing. So the first example that I'll give is a Fanconi anemia again. So by the 70s and 80s, when people are saying that we can't actually diagnose these altogether, they're studying the cells from the patient, so this is patient-directed research, and realizing that they actually have a sensitivity to DNA-damaging agents in a very peculiar way. When those agents are given, these are the normal chromosomes from a person, but when those agents were given, this is what happens to the chromosomes of a patient with Fanconi anemia. They develop all of these different types of breakage forms and radials, etc. You can see how abnormal these are, like this form over here. And this became very useful as a diagnostic. So even before the genetics was known, this became the way that you actually now define this disorder in families. It was very sensitive for picking up whether or not there was an actual underlying problem, regardless of whether you had all those clinical features. And that had to be proven, and it turned out to be true. And what it ultimately did was change the definition of the disease. You could have those clinical manifestations, but the way you were going to categorize this was based on a cellular basis, that you had broken chromosomes when you used this test, and that was now going to be called a diagnosis of Fanconi anemia. That was before, again, the genetics were known. In another example that I'll give you, in dyskeratosis congenita, this is after the genetics were known, but people realized that this had to do with another part of the DNA, the very end of the DNA, which is called the telomere. So the telomere is a set of repeats at the end of every chromosome in the cell, and you can think of it as a protective end to a linear structure like a lace. So this is the aglet of a shoelace, and that's familiar. And that is important to keep this from fraying and basically destroying the regular part of the genome. And we won't go into the whole molecular biology, but really what the patients with dyskeratosis congenita have is a problem in maintaining this telomere end. And so what they really look like is this, is that aglet has gone away to get this frayed end of the chromosome, and that causes all sorts of problems in the cell, and for the cell to die prematurely as well. So acknowledging this, and we won't go through all the details of this, it became possible to count and measure the length of the telomere in the cells of patients who had bone marrow failure. And whether or not they had that full syndrome that I described to you, this is a really powerful study that was done by Blanche Alter at the NCI and her colleagues, and Peter Lansdorp, who developed this technique, is to say that in these patients who have dyskeratosis congenita, we can measure their telomere length, and they fall in this very, very low range compared to other patients with bone marrow failure, not even the normal population. The normal population is these lines here. So this became useful for diagnosing dyskeratosis congenita and changed the detection and clinical practice. And this is around the time that I was a fellow or finishing my fellowship, and I don't know that I had actually seen these patients, but we realized that we were missing them too. We were actually looking for those classic manifestations, and we were not seeing them. This type of test has showed us that these patients are coming and going, and we're not actually diagnosing with this as well. So these types of tests are very powerful, and again, change the definition of the disease. So finally, genetics. So in parallel with this, and again, influencing the functional testing, has been genetic discovery, taking cohorts of patients and using more and more powerful genetic techniques to find the genes underlying. Even if you don't know how they're causing the disease, which remains true to this day, you can actually say, this gene is abnormal now, and we can actually diagnose you with this too. So it becomes a parallel way, separate from a clinical manifestation, that lets you diagnose the patient. And this has become very powerful, and it has its strengths and weaknesses, and we'll talk about those. So just to get everyone on the same page, I know you're having a genetic session, and you probably hear a few things over and over again today, but there's different inheritance forms of how you pass on a genetic disorder. So we all have 2 copies of every gene on most of our chromosomes, and in an autosomal dominant form, a person is affected when one of the 2 copies is abnormal. And then they can pass along one of those 2 copies, a 50-50 ratio, to their children. And that passage alone would, in the classic autosomal dominant inheritance pattern, lead to the disease manifestation. So in this case, the father having one abnormal copy is affected, passes on one abnormal copy to half of his kids, and that actually can cause a problem. The other inheritance form that's familiar to you too is autosomal recessive, meaning of those 2 copies, the 2 copies have to come together abnormally in the child to have a problem. So the parents may be unaffected. The parents may carry one abnormal copy, and 1/4 of their children may inherit then 2 abnormal copies and be affected by the disease. So in that case, you may not see a family history, for instance. It's new in the child, apparently, but it's come from the parents. There's another form called X-linked recessive, which we won't talk about too, but that's where you pass along something on the X chromosome, so mothers pass them to their affected sons, and their daughters become carriers 50% of the time. And then there's also the category of de novo, or apparently de novo, where it's a brand new mutation in the child, and that actually causes the disorder, and you can't find it in the parents, even though there are complexities to that too that may be there, but you just can't see it. So with that framework in mind, the genetic discoveries that came from many different angles, from cohort studies, registry studies, application of classic genetic approaches, et cetera, candidate gene evaluation, you now have the genetics in the past 20, 30 years of marrow failure being elucidated. And there's several features that are actually really interesting to point out here. First of all, there's lots of genes. So in Fanconi anemia, there's now 23 genes that account for 95% of cases. In dyskeratosis congenita, about 18 genes accounting for 70% of cases. In Shwachman-Diamond syndrome, genes have been found that account for most of them as well. Diamond-Blackfan anemia, more than 20 genes. And there's even one genome we didn't talk about, which is the mitochondrial genome that can cause a childhood marrow failure disorder called Pearson syndrome. So these are interesting because, for several reasons. First of all, these actually are fundamental parts of the way a cell works. This is DNA breaks, like we talked about. This is telomeres. This is how proteins are made in a cell. So that's a very fundamental function of every cell in your body. This is how energy is produced in your cell. So you see, you have these disorders and these fundamental factors, and you're getting syndromes that actually are pretty severe, but sometimes not as severe. And one of the common things that's happening is that the blood is failing, the bone marrow is failing. Why aren't they more severe? Why aren't they actually not allowing the cells to live at all and not having a person available? And that's because these mutations are usually not total loss of function. So there's some partial loss of function that lets some function happen in the cell, but the cells are stressed. And so it starts to make a little bit of sense that there's a partial loss of function. These cells are trying to be a lifelong supply of other cells and blood forming capacity, and then they have this difficulty as well too. And it also shows you that at the end of the day, we can try to explain, and I'll give one example of why the bone marrow fails, but we still don't actually really understand exactly why these are causing the precise manifestations in the children that we see, and that's part of our challenge. So if you now broaden this to other marrow failure disorders, I told you about 5 of them. Now there's many others that have been discovered. This is what, of 20,000 genes in the genome, what a current gene panel would look like if a patient presents with bone marrow failure, and we want to know, is there an inherited form of this? So this is the Cincinnati Children's, as one example, 165 gene panel. So for the rest of the time today, we'll just go through every single one of these genes. I'm just kidding. But the point really being made is that this is a challenge. It's a challenge for all of us to navigate this, and that's part of what the challenge is for pediatrics in terms of being able to precisely diagnose bone marrow failure. But we've come a long way because we don't want to miss these, and I'll tell you why. So how can you use that information? So the way we actually, beyond the functional testing, beyond the clinical evaluation, we'll send off this gene panel. And there's 2 ways that it happens, and this is quite remarkable technology. So out of all the DNA in the cells that are provided, these genes are pulled down and then they are sequenced. Or you can actually just go ahead and pull down all the genes that code in the entire genome and sequence all of them too. So you'll get less coverage, you'll get less depth, you'll get less accuracy, but you can study all those too. So the first one's called a targeted gene panel, the second is called whole exome sequencing. In both cases, what you're going to do is compare the sequences that you get back to a reference genome, a normal. Doesn't mean that that's normal for everyone, but a normal sequence. And you'll then classify them as normal, or we don't know. This is a big, important category, variant of uncertain significance. It's just different for you, and it doesn't actually have any relation to disease, or is it actually disease-causing? And then there's others that actually now have been proven in a variety of ways to be disease-associated. So you end up with 3 outcomes at least. So several points to be made about this. So the first is that these genetic discoveries have actually revealed now, not just that there's such a complexity in bone marrow failure itself, but there's other disorders that are out there that people thought were unrelated, would have never connected, but they actually have a common genetic basis too. So an example I'll give again, and you'll see that, of course, I focus on telomere diseases a little bit. And this is quite a remarkable discovery, is that in the ability to measure telomere length in people, and the ability to actually find genes that affect telomere length, and then looking at families and saying, well, this person has dyskeratosis congenita, but this other person who's in another generation of the family doesn't seem to have that, but they have this other disorder. Why do they have this other disorder? And soon you find that actually this is one of a spectrum of disorders that are caused by some partial loss of function in telomere maintenance and the ability to maintain telomeres. And it's quite clear now that the severe childhood forms are just a fraction of what are more common adult forms. So these dots represent when the patient presented and what their disease was called. So Hoyer-Alder-Peterson syndrome, which most people have never heard of, is a severe form of dyskeratosis congenita that presents earlier. But myelodysplastic syndrome, presenting in an otherwise normal-looking person, or liver disease when you're 50, or pulmonary disease when you're 55 years old, some fraction of those patients who have these diseases for no known reason actually carry mutations that are the same genes that actually cause dyskeratosis congenita. They also have very short telomere length too. And this starts to now make this a spectrum of disorders that affects more people. They're still rare, but this is not 1 in a million anymore. It's more like 1 in 10,000 or so. And those genetic discoveries also inform maybe a little bit, because we try to think, okay, why? How is this connected to what we're seeing? Why the bone marrow fails? So I already told you that the blood stem cell is responsible for producing billions of cells a day. And I told you about these telomeres that end up being important for protecting the genome. So the one thing that you need to know is that as we age, based on those graphs, our telomeres are shortening in all of our cells in normal people. So that's part of our ability to create stem cell function and create regenerative capacity as we age. It's a form of cellular aging. So if we are aging at a certain rate and our telomeres are shortening, but we need our stem cell to actually proliferate and divide millions of times over our lives, we can sustain our blood system. But if you actually have a problem with the telomere or a problem with being able to maintain it, you will have a shortened span of that, like less gas in the gas tank, essentially, and you will have marrow failure perhaps earlier in your life at some stage. So that's the way we conceptualize it. Makes sense for blood stem cell failure, but it still doesn't explain, for instance, why the lung problem, why the liver problem in the adults who are, and that's part of the challenge of what we have to figure out right now. So what about the limitations of genetic testing? So is it all the end all and be all? But it's not. So once you get these panels back, they take a lot of careful thinking about how to interpret them. I already talked about how you might have a variant, and whether or not that is related to the disease or not can put you down the wrong path. You see a rare variant, it's never been seen before in any other people, it's in a gene that kind of fits what you're seeing in you, okay, you have that disease. So that could be a mistake. To diagnose you with a disease that you don't have based on a genetic test where you can't interpret appropriately the genetic test. So we spend a lot of time thinking about how to classify and how to validate and how to make some sense out of these variants that people may have. The other thing is you get a lot of strength in looking up and down the family tree and seeing if that variant is there. Is it new or is it tracking down in a family? And if it's tracking down in a family, why isn't the other person affected? And should that be helping strengthen the argument that it's disease causing or not? That would make sense. But there's a high degree of variability between people. The same exact mutation in two different individuals can result in someone being relatively unaffected and someone having a severe syndrome. And we don't understand all the determinants of that. That's called pleiotropy. The other complexities that you can see, and this is another example from DC, is that actually there is a phenomenon where passing down a mutation every generation makes things worse. And so people can present at a younger age with the same exact mutation, and part of the reason for that, conceptually, is because they're inheriting short telomeres as they're getting into further and further ages. So that's been proven for this disease, at least. And then finally, and we'll see this when we talk about MDS, there can be pressures in the blood system. So when you test the blood for genetic disorders, there can be pressures in the blood to try to fix or compensate for that mutation. And some of those fixes and compensations make that mutation not necessarily appear in the blood of other people in the family tree. Rare, but these all need to be taken into account before you rule in or rule out things. So this is a good example that we'll talk a little bit more about later in the MDS section of a mutation in a gene called SAMD9 or SAMD9L that's on chromosome 7, and the cell doesn't like it at all. It wants to get rid of it. And one of the ways it does it is to actually get rid of it. It basically will knock out that chromosome, or it will basically copy the other chromosome and put it over here. And so you may say, well, this is a new mutation in the child, but actually the parent had it too. It's just that in their entire blood system, they actually flipped it over and got rid of the mutation too. So we have to be very, very careful in how we call genetic variants and how we basically call genetic diagnoses, even looking at all the parameters that we have. So what are the implications? So there are important implications, including how you treat the marrow failure. So when you diagnose a patient with acquired aplastic anemia versus an inherited form, the pathways could be quite different. Whether or not they get now an immunosuppressive therapy or transplant, maybe we're hearing a lot more about that. But I'll just point out how you do the transplant, with whom, who the donor is, when you do the transplant, in their disease course. These things matter. The diagnosis matters a lot for that. And also the possibility of other treatments, because in some ways that are known and unknown, some other drugs actually help with the blood problems in patients who have certain diagnoses as well. And also in terms of thinking about novel therapies. This is also important for thinking about prevention of other associated problems. So if you diagnose the syndrome in a person who doesn't look like they have a syndrome, you may now go looking for those other problems that are not yet clinically relevant, but are something that's going to happen that's going to cause a complexity in therapy, or a complication for the patient that they may have, that their liver has problems later on, et cetera, or that they're prone now to developing MDS. So that's why diagnosis matters. And beyond that, there's a huge impact on the family in terms of family planning and counseling for parents to think, is this a genetic disorder or not? When we're thinking about having other kids, screening other family members, and like I described to you, not just the siblings, but basically going up the family tree into other generations. Sometimes the child's disorder can actually precede the parents' manifestations of the disorder, and also in terms of basically having people develop a sense of arriving at a diagnosis and allowing them to have the opportunity to participate in advocacy and disease-specific research that may be helpful. So the lessons we've learned in pediatrics is that about marrow failure disorders, at least of course across the course of even my career, is timely diagnosis is critical for appropriate care. The clinical features and family history are important but unreliable to exclude the diagnosis. Functional tests are powerful tools that change the definition of the disease, and genetic testing is also powerful and should be done, but carefully interpreted. Does the inheritance follow the expected pattern or patterns? Variants of uncertain significance need to be taken into account, and you may require testing of non-blood samples, such as skin samples, to look for whether or not this is something that's in the whole body or just in the blood. And so our approach in pediatrics is basically to do all of it. And we basically take, as I described to you, very comprehensive histories and physicals, do lots of labs and functional genetic testing, and realizing that our eyes are letting us down to the best of our capacity, we essentially send at our center almost all of these tests right off the bat and try to wade through them carefully all of the data that we get back for all children presenting with marrow failure in a timely fashion because they sometimes need an intervention. So despite doing all of this, where we land? Like I said, it's not necessarily easy to end up with the diagnosis. So in some cases, and we're actually sometimes referring to each other, even within our marrow failure program, people who have a relative disease-specific expertise for dyskeratosis congenita or Fanconi anemia, and sometimes we can rule out that it's that variant or that disease that people thought might be going on, and that will be follow-up as needed for their marrow failure with their provider, even for a referral from outside. When we rule it in, we treat accordingly, try to give best guidelines for that particular disease if one's going to exist. But sometimes we end up in another category still. It's not uncommon to be uncertain, and it's not needed. So it's not certain, but when no intervention is needed, we continue a patient and family workup, and oftentimes now expanding to the family is really, really important. And finally, when we have this scenario of basically it's still uncertain, but an intervention is needed, this becomes the management complexity and basically the art, I think, that you try to accelerate the workup the best that you can. You counsel the patient about the things that you know and you don't know, and say where you stand in that thought process, and offer the things that would be available for that, trying to minimize risk and optimize the ability to arrive at a diagnosis in a timely fashion. And sometimes if there's a clinical trial available, you can use the trial eligibility to determine whether or not they should go down that path. And we've done that in the past too. So that was the background on marrow failure. And now I've been asked also to speak about MDS predisposition syndromes, and it ends up being very similar in framework, and we'll add some more complexity to the way to think about this too, because essentially the punchlines are that there's more evolution going on in these blood stem cells at a genetic level that make things even more complex to understand and may provide an understanding of why MDS is happening, and that there's an intersection of this stress in the marrow failure state and the development of MDS. That's the framework currently. So go back to our conceptual framework is we have our blood stem cell, we have our healthy garden of marrow over here, and myelodysplastic syndrome is essentially mutations in the blood stem cell that compromise its function, as a simplified way of putting it. And it's a form of blood cancer. It doesn't allow the cell to do what it's supposed to do. It changes over time, and it can lead to a more fulminant acute type of leukemia. So what's happening at some level is that the blood stem cell over the course of age and life, and now it looks like this happens to all of us, accumulates some mutations. This is probably happening everywhere in our body over time. And those ones you can consider weeds. Sometimes they cause problems, and sometimes they don't. They remain relatively indolent. And these then are one step along the way, perhaps, to developing MDS. And then you have a marrow that doesn't look right, has dysplasia. So the categories, once again, the most understandable category is that it would be age-related, that we don't know exactly why it's happening, but these are probably going to be unified by finding mutations that happen just in the stem cells as you grow. The second one that's very clear here is that these can be secondary or treatment-related. People after they've gotten therapy for cancer, for instance, with radiation or chemotherapy, can actually now develop a treatment-related MDS AML, and these are known to happen and things that often are very, very hard to treat. And third are the sequelae, the other problems that happen when you have an inherited marrow failure syndrome. So these look familiar. These are the same disorders that we talked about before. We'll add a few more that now have been defined more as MDS predisposition syndromes, perhaps a little bit less as marrow failure syndromes too. So what's happening here? So where and when do the mutations that drive MDS occur? So here you have normal blood stem cells, and as you age, they try to remain normal, and periodically they acquire a mutation, and some of those can have a bit of an advantage, and so they become apparent in the blood, and you can see that in the genetics. This is called clonal hematopoiesis. At some level, this elevates the risk of people developing MDS, but it's still very rare, and these are small risk augmentation, but this happens more and more with age. However, if you now try to think of the intersection with marrow failure or with any other stress on the blood stem cell, if you already have a chronically stressed blood stem cell, it has a higher rate of acquiring mutations that actually expand because it is trying to get away from its stress, perhaps too. And once in this state, depending on how it mutates, it can actually start to accumulate additional mutations that can lead to leukemia or can be indolent for a while. So this is one way to think about why a marrow failure syndrome will actually accelerate the progression to MDS. I'm showing this slide because I think it's very, very interesting that in the past, I'd say just almost a decade now, we have known, and I've already alluded to the fact that Fanconi anemia, telomere biology can lead to myelodysplastic syndrome. But it's become very interesting to find that there are actually mutations that are inherited that now have a kind of stereotypical age of onset of MDS. When I was a fellow, we had patients who developed MDS in a family who were 2 years old, 3 years old, 8 years old, 10 years old, and we didn't really know. We knew that there has to be something genetic, but we didn't actually really know why. It turns out that they actually have inherited certain germline mutations, and that's actually flowing in the family. Sometimes they've inherited from the parent, but the parent has changed in some way that doesn't let that actually turn into a leukemia for them. And most recently, and we'll give this example too, that there's actually germline mutations that are now showing up as MDS, causing at an age of onset that's not really distinguishable from what happens in typical age-related MDS, and those are DDX41. So the examples here, GATA2 deficiency. So this was described as a mutation in 4 different syndromes when people were clustering people who had similar sorts of presentations, but different from each other, not necessarily clustering them across each other. And all of a sudden in these 4 syndromes, the same mutations being found. So all of them are linked, and all of that variation is just the way it manifests differently between different people. So there were immune deficiency, lymphatic defects, and an MDS predisposition. And one of the families that I was telling you about before had this that I didn't actually know about in that era. So these are autosomal dominant, they're often de novo, and they account for 15% of advanced and 7% of all MDS cases in childhood. So that's a pretty appreciable number. SAMD9, SAMD9L mutations, these were described in 2016. Again, this is not a copy-paste error, in 4 different syndromes, and they happen to have a shared genetic basis. Neurological defects, immune deficiency, other abnormalities, sometimes you have those things, sometimes you don't, but you have marrow failure and MDS. Chromosome 7 abnormalities are common, and these are sometimes MDS defining. It happens to be that this gene is actually on chromosome 7, so one of the ways that it fixes that, because it doesn't like having this mutation, is getting rid of the entire chromosome. And that leads to MDS. And this has to be thought of very, very carefully about whether that's a good accommodation or if that's actually MDS defining. And we'll get into that a little bit. So 17% of MDS cases in childhood actually are caused by SAMD9, SAMD9L mutations too. And you can tell all these papers are relatively recent here. The MDS risk in those more classic inherited marrow failure syndromes for a long time has been known to be elevated. And here in a prospective study by Blanch-Alter, it is now in the NCI registry quantified as being hundreds to thousands of times that greater than the general population for DC, for dyskeratosis congenita, Fanconi anemia, and Shwachman-Diamond syndrome, and there are others as well. So how to think about this? So in a germline mutation status, you can have mutations, and sometimes those mutations, which are now called, or as a model, adaptive. A change has happened, the cell is better off, would be better off without any mutation, but it's a little bit better off, and that can actually go on and result in the blood functioning reasonably well enough. You can consider that a good clone. How about if there's a maladaptive or a mutation that actually is accommodating for the stress, leading to blood production, but also destabilizing the cell in some other way? And that could basically be what happens previous to developing a bad clone or MDS AML. And this has now been documented in Shwachman-Diamond syndrome in a really beautiful study by my colleague Alyssa Kennedy and Akiko Shimomura, where they sequenced patients who had germline Shwachman-Diamond syndrome disorder. And it had been thought that this actually has a problem with the ribosome, like I mentioned to you, in proteins, and it turns out that a lot of these patients will develop a good mutation, an adaptive mutation, in another part of the ribosomal machinery called EIF6, and that's now considered a somatic genetic rescue. It rescued the cells, and those cells will actually go on and produce reasonably good blood function. But those patients can also develop this maladaptive mutation to get over the cellular stress. They mutated a well-known gene called TP53, and by the time they developed 2 of those mutations, they actually have MDS, AML, and their outcomes are very poor. And this is why it matters. This is the outcome of Shwachman-Diamond syndrome transplants when you have marrow failure, and this is the outcome of Shwachman-Diamond transplants when you've developed AML, MDS. And this is the outcome of transplants when you don't have a TP53 mutation, a maladaptive mutation. This is the outcome of transplants in orange when you actually have developed a TP53 mutation as well. So these are basically studies in these cohorts of patients dependent on their genetic status, adaptive versus maladaptive changes and underlying germline disorder. So for this reason, in patients who we identify at risk of MDS by virtue of their germline genetics, we then perform marrow evaluation in an imperfect way to try to catch it and try to basically say, well, we don't want to transplant them yet, but can we catch it before they're about to become MDS, AML, and intervene at a timely fashion? So we haven't gotten the upfront risk of transplant, but we've actually hopefully gotten them before MDS. And this is an evolving standard. We will do it at a given interval depending on their disease category, age, what their peripheral blood is doing, what our plan is when we get the piece of information, the procedural risk, and the patient family choice. And the innovative piece here, so what we usually do is we assess cell numbers, shape, and maturation, so that's this stuff here, chromosomal changes here. But those are seeming like they're pretty blunt. They're probably pretty late to actually be detecting those things and actually intervening. So we have a little bit more hope now in looking at these somatic mutation gene panels. So if you basically start to track the genetics in these patients and you look for small evidence of small changes in the genes that are portending it turning into MDS or AML, that's where we want to actually try to be able to intervene here. So I'll quickly close by just talking about what about adults who don't actually have a previously known genetic disorder? What are we missing? So we talked a little bit about DDX41, so it turns out that this is an adult onset MDS due to an inherited mutation. They're found in 2 to 6% of myeloid cancers, and it's the most common known genetic cause of MDS predisposition in adults. And unlike IBMF, marrow failure associated MDS, these patients develop it around the same age, and these are like second hit disorders in a dominant sort of fashion. And the question becomes, is this the first of knowing that MDS is actually a germline disorder in adults too, or is it an exception in adults? I'll give you one example quickly of another example of what we're missing and why it's important. If you go back and sequence all the patients who got transplants for MDS over the course of many years in the registry called the CIBMTR, you find out it's not tons of the patients, but actually 3% of them had a mutation in a gene that causes DC. So they actually had an underlying telomere disorder that was not known by the time they were actually transplanted. And to find that mutation, you basically have a worse outcome by doing the transplant the way it was without necessarily knowing it. Whether or not you can intervene and be different, not clear, but it is having an impact on outcome. There's another example, but in the interest of time, I'll skip that. And then finally, one important point to be made is, because transplant is one of the interventions, if there's a familial disorder and it's subtle, you may miss it in the sibling that may be being used as a transplant donor. And there are examples, and these are small examples, but probably important too, of basically people having the donor be an unaffected sibling in an adult age of MDS, and that actually not going well because that patient also had a problem with their blood stem cells here. This is a 2003 paper on dyskeratosis congenita, and there's evidence of this in GATA2 deficiency and also in DDX41 as well too. So, which adults with MDS should be evaluated for a germline mutation? The pediatric view would be everyone, I think, and I think that would come from, it's probably just to be provocative, because we have decided that we actually can't figure out who does have problems and who doesn't. And you can ask lots of questions about what would you do with the information and what's the yield, et cetera. And so maybe one set of guidelines could be people who are presenting younger, people who present with looks like hypocellular MDS, marrow failure, family history of any manifestations, which are hard to ascertain, and those that start to show variants in germline genes or somatic gene panels that are indicative of that, and also when using a family donor for HCT. We might want to scrutinize that situation a little bit more carefully. But still, the pediatric view would be everyone. So the lessons learned in MDS predisposition disorders are many marrow failure disorders are MDS predisposition disorders. Pediatric MDS is commonly due to germline mutations, and some adults with MDS have germline mutations, and that these are likely underdiagnosed, that these genetic
changes reflect adaptation to cellular stress, and you have good versus bad clones, and intervening before MDS is important because of the poor transplant outcomes. So our approach in pediatrics anyway is to try to do surveillance like I described, and it's evolving because we'd like to use and hope that gene panels will be more useful in detecting early and interrogate germline disorders in children with MDS AML. That's also not a standard, but increasing. If a child presents just with AML, then to try to find what the underlying disorder might be. And we are, because this is now clearly a continuum, we are collaborating much more with adult providers. They are learning from us about our germline disorders, we're learning from them about MDS and its interventions because we don't have we don't have as much experience as good therapies in children. And finally, we need to develop safer transplant and other interventions to help prevent MDS, to not fall into that situation where we're watching and miss the boat. So I think I will skip the last section on research, unfortunately, for another day, and just come to the end here, where what we've learned is, we follow children over time and try to make the interventions that we need. We're very much in line with, I think, the mission statement of the AMDS International Foundation, the life-changing phase of the diagnosis, the life-threatening phase of the treatment, and then recognizing that this is a chronic disease in these patients, trying to provide lifelong support for them. So when you're 2 years old and you have an inherited marrow failure syndrome, and you've done the transplant for these patients, and you basically are able to get them over that hump, even with a tailored therapy, which I can get to describe to you, the question is what comes next, and what can you actually do about it for them? So I will just quote one of our icons at our center, that the treatment of ill children may allow a physician to have decades of experience with individual patients through their growth and development, and that the physician may not have the proper tools at the first encounter, but biomedical science may in time develop those tools, and all the physician needs to do is keep trying and hopefully live long enough to see the victory. And this is David Nathan, who essentially is the founder of our division at Boston Children's. So this is our goal. I think it's very much aligned, and I think we basically draw on the resources of all the knowledge that we can, both from the adult and pediatric side. So thank you very much again for allowing me to participate. I want to recognize patient advocacy groups that have been very important, both in the work that we've done and also provided support. Team Telomere is represented here, and the Champ Foundation for Pearson syndrome, that very rare disorder, and also these funding sources who have committed themselves to investing in marrow failure research, which is also rare, and then of course the AMDS Foundation and you for your attention. Thank you.
Thank you so much, Dr. Agarwal. We have time for just a couple of questions, so I'm going to go ahead and start with the first question we had online. It says, can you speak about the generalization of this genetic information to the development of the acquired disease of PNH? There seems to be similarities in biology and even terms like clone. My daughter was diagnosed with PNH 1 year ago.
That's a very good question. I think that I'm not an expert in PNH. It is more of an adult disorder than in children. PNH clones are seen in children and are more often associated with a stress that the cell is trying to get away from when there's an immune attack on the cell. So we tend to lump those to some degree, and based on some good data, with acquired forms where the immune attack, there's also an evolution, a genetic evolution against the immune attack in the blood stem cell, and PNH may be one outcome of that. Whether or not the inherited forms then would themselves lead to the manifestation of PNH, I think we're thinking of those as two different buckets in some ways, but I can't say speak definitively about that.
Thank you. Do we have any questions in the audience?
Do we have any questions in the audience? Sure. Let me bring the mic over so everyone can hear online.
I recognize you're talking mostly about inherited, but I'm also curious about acquired. Could you respond to the efficacy, I guess, of the combination of radiation therapy combined with exposure to chemicals such as benzene in causing an acquired ABS?
So can I speak to the exposure to toxins such as benzene in acquired MDS?
Yeah, benzene in combination with a prior treatment of radiation?
Treatment of radiation. To the best of my understanding, both of those are sufficient in and of themselves to actually lead to there's a higher risk of developing MDS. The mechanism that one would put forth, certainly for radiation, would be the stimulation of mutations. So if mutations in blood stem cells are the path to MDS, then radiation certainly would. Benzene would be expected to do the same. So these are DNA damaging agents that would accelerate the process, perhaps even on a normal background, normal stem cell background, of having more variety of the stem cell to choose from in terms of whether or not it was going to become a bad clone, for instance. And the cell will choose in some ways, sometimes if it's actually overcome one of the gatekeeping functions of becoming. So the cell has many functions that basically prevent, if a mutation has happened that will lead to cancer, of actually stopping that, right? So that's happening in us all the time. If a mutation happens in those genes stimulated by an increased probability from a toxic exposure, that cell may escape then and become a cancer.
Thank you.
Okay, thank you so much, Dr. Agarwal, for sharing your time and your expertise with all of us today. If you'd like to watch this session again at a later time, it will be available on the AAMDS website, and it's also going to be available on the conference platform. If you have any additional questions, you can let us know. We're happy to get you the answers that you would like today from some of our other experts. I'm sure some of these questions you may have can be addressed in the rest of the topics for the day. But if you'd like to send us your questions, you can send it to us to our email, which is help@aamds.org. You can always give us a call at 800-747-2820. Or if you're on social media, you can always submit your questions to us on our Facebook page. If you're watching online, please take a few minutes to complete the session survey. And for those who are here in person, you will be receiving a survey from us to your email later today at the conclusion of the conference. Please do take a few minutes to complete the survey. Your responses really do help us with planning our future programs, and your input is very important to us. Our next session will be starting in approximately 10 minutes. If you're here in person, please take a few minutes to stop by and see our sponsors who were able to join us here today. And if you're online, take a look at the exhibitor booths. They have lots of information there. And if you're interested in speaking to any representatives, you can leave your information and they'll reach out to you next week. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you so much for joining us and always making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. It's always our pleasure to help you with receiving answers, support, and hope. This concludes our session.